Okay, I'm going to start. Very good afternoon to everyone. Thank you for joining our MOH CFPS webinar on clinic inspection as well as the launch of the new clinic resuscitation drug and equipment training module. My name is Nelson. Before we start, I do have some administrative instructions to share with everyone. Next slide, please. Please kindly attend the entire 2 hours of the webinar, as this webinar is accredited for 2 core CME points. Secondly, the slides for this webinar is downloadable on our e-learning website, which is Wislearn. You should, and I encourage to read the slides before you attempt the MCQ. There is an MCQ component which will open on coming Monday, 29th of September at 12 noon, which you can log at the website. And if you have any issues logging into this the website, do approach us at sfp@cfps.org.sg so that we can give you technical assistance. Completion of the CME does come with of the MCQ does come with additional CME points. So everyone is strongly encouraged to attend the full webinar as well as attend the MCQs, right? We will make available a recording of this session and it will be available on our website on cfps.org.sg. So if you wish to revisit any of the core topics or re-look at any of the core topics, do feel free to go to our website to watch this recording. Lastly, there is a chat function under the Q&A. So click on the lower right-hand corner, the box with the question mark. Because if you have any questions, our strong group of panelists and resource persons from both CFPS and MOH will assist to answer any questions. Next slide, please. We have a few gentle reminders. We are at the next cycle of the Healthier SG Care protocol. So CFPS and MOH has combined to create a series of 3 webinars on the date listed. So this is the first wave. So we do strongly encourage everyone to sign up for the Healthier SG Care protocol webinar. This is a free webinar for everyone. So please sign up to get both core points as well as better understand the next cycle of the Healthier SG Care protocols. Next slide. And on behalf of Director PCC and MOH, we would like to remind all our Healthy SGGPs to submit your HSG care plans and your patient indicators for your enrolled patients before the end of 2025. As of 4th September, less than 50% of the enrolled patients have their submission done. So we strongly encourage everyone to do your submission. You can either see in person or you can teleconsult the enrolled patients to get the care plan and submit your indicators, right? And if you require any assistance, for instance, you have some CMS issue, your PCDS information is not accurate, do consider contacting your PCN HQ and your AIC manager for further assistance. Next slide. Okay, to today's webinar. Today's webinar is a 2-part special, and we would like to, on behalf of college, we would like to thank the Ministry of Health for taking out time to partner college for this webinar, which is requested by high demand from a lot of GPs. We'll be covering 2 key areas, one on the MOH clinic inspection process, as well as on the newly launched resuscitation drug module. Next slide. So a quick rundown of today's program. We will next invite our president to give a briefing, followed by the first part, which is the MOH clinic inspection process, and then the resus drug launch explanation. And then we have a buffered sufficient time for Q&A because a lot of you may have concerns about the process or certain questions about the resuscitation drug or some key concerns. And all these will be addressed at today's webinar. And lastly, we're very grateful that Deputy Director General of Health, Prof. Raymond Chua is here today with us, and he will deliver some closing remarks at the end. Next, I would like to invite our President, Dr. Wong Tien to deliver his opening address. Dr. Wong, please.
Thank you very much, Nelson. Thanks everyone for joining us this afternoon. And also a big thank you to our MOH colleagues for agreeing to run this webinar together with the College of Family Physicians. And as what Nelson said, today's webinar is really based on the demand and the feedback we had from many of our sources and our own chat groups, talking about some of the issues and pain points they experienced when they underwent MOH clinic inspections. So this afternoon's webinar is a bit special. It's not the usual academic, we're not talking about hypertension or care protocols, but really about the practice side of family medicine, right? And I think I see many of you here today. You're probably clinic managers. You're probably owning your own clinics. And I suppose you've also experienced clinic inspections or yet to experience clinic inspections. So as you know, all healthcare establishments operating under the Healthcare Services Act or HCSA are subject to inspections by the Ministry of Health. So these inspections are essential, right? Because they ensure that clinics meet the required standards for licensing and safe operation. And they will cover many aspects of our daily practice, right? from not just physical facilities to safety measures, but to the standards of your equipment, to infection control, to waste management, and other processes. To be honest, nobody really enjoys being audited. I am also part-time part of auditor, and we also don't really enjoy auditing people lah. But for both parties, right, it tends to be inconvenient, right? It's actually stressful to be audited, and can be very uncomfortable at times. But I think it is a necessary pain. I can think of three key purposes of an audit. The first is that, most importantly, is an external verification of the good standards that we are already maintaining. And I do believe that many of us, the majority of clinics operating in Singapore, all right, we have no major issues with inspections. You do get a bit of this and that, right? I mean, I know we are doctors in Singapore, you want 100% pass mark lah. Then we get 95%, you feel very hurt, that 5%, why you don't give it, but actually you passed. It's just that there's a bit of feedback. Right? So just take it as a little bit of feedback. All right. You are all doing pretty well. All right. Seriously, this is the truth. Secondly, audits give us feedback in areas where safety and quality of care can be further improved. Sometimes we don't see it, right? We walk in and out of our clinics every day. We didn't realize that the waiting room, that the plant is dying and rotting fruits, we didn't know, right? So you need someone external to come and tell us about it. So it's okay. It's just feedback. And thirdly, audits also assure the public that anyone holding a license has met the basic standards of safety required to operate. So let me assure you that the inspectors are not going around to find fault with random requirements. All right. After today's webinars, you'll find that the process is transparent, expectations are clearly set out, and MOH is more than happy to share their procedures so that clinics know exactly what is required. In fact, the reason we asked to collaborate with MOH, of course, is that based on the feedback, we are able to address these issues. In line with the theme of the preparedness, I'm also happy to share that we're launching a new course on the administration of resus drugs and the use of resus equipment. And this short course will cover the list of resus drugs and equipment required in clinics, the management of anaphylaxis, and a practical run-through on how to use the equipment found in the emergency kit. So it's a fantastic and a very timely refresher course for us on how to respond swiftly and effectively in a real emergency. Seen in this light, audits and training courses such as this are not just about compliance. They are about building trust and safeguarding our patients who place their health and well-being in our hands. Thank you very much for joining us once again.
Thank you,
Back to you,
President.
Nathan.
Thank you very much. Next slide, please. We'll start with the first key part of our talk, which is a presentation by the Ministry of Health on understanding the MOH clinic inspection process and how to prepare for clinic inspection. We're joined by Ms. Caroline, who is a very seasoned veteran auditor from the Ministry of Health, and she'll give you all the tips and all the guidance and demystify the entire clinic inspection process, right? May we invite Ms. Caroline to share with us? Thank you.
Okay. Yes. Afternoon. We thank the College of Family Physicians Singapore for having us in this webinar. I'm Caroline Tan, and I'll be sharing on the key preparation areas for our clinic inspections, including activities to expect during the inspection. Next. We will cover these topics to provide an overview of key areas to consider when preparing your clinics for licensing. Do explore further after this presentation as well in the HACSA website and also our checklist. So for the background of HACSA, we'll cover that, followed by delving deeper into the areas to prepare for your clinic. Next slide. In the early 2020, we have implemented the HACSA, which sets out a service-based approach to licensing and regulation of health services. with the move from location-specific brick and mortar licenses to service-specific licenses. Next slide. With the implementation of HACSA, 4 modes of service delivery are made available, namely permanent premise, temporary premise, to cater for house calls, in other words, home medical, remote services through virtual GPs, phone calls, chats, and also emails, and conveyance. These provide better avenues for service providers to reach out and attend to their patients for the more stable ailments or conditions without the need for patients to come to the clinic, especially if they are hard-pressed for time. Touching briefly on remote services, this service encompasses seeing patients through teleconsults, phone calls, and text messages. We will cover this aspect of remote services later. Next slide. The specified service common to GP clinics include electrocardiography stress test, or EST, which may be offered as part of cardiac screening or your health screening services. To provide such treadmill as a specified service, you will need to have obtained MOH approval upfront as part of your clinic license. You will see an option in Help website where you can indicate that you intend to offer electrocardiography stress test for your clinic. Do explore the help website, okay? Next slide. Here are the overview of the specified services relevant to various licensable healthcare service settings. You will also be able to delve into the relevant regulatory information in HACSA website as shown in this table. You see the extreme right column. Next slide. Please note the defined roles of holding a clinic license. You can take a minute to scan the 4 roles. Your attention is drawn to the clinical governance officer who assists in clinical governance and technical oversight of the complex services offered by your clinic. So he or she will need to have the competence, the expert know-how of the services provided. And the next one is principal officer that ensures the overall operational compliance to HACSA. Can click again. Yeah, do note that the same individual can be appointed for all these roles, subject to him or her meeting the specific requirements for each role. Next. Why do we carry out inspections? So these are the rationale. It's mainly to safeguard our patients, the public, and also our team. That means the doctors and their staff as well. And you can see in the point 2, inspections are now dealing from license renewal cycle, meaning that if your license is due for renewal on the 17th of February next year, which is Chinese New Year, then you can make alternative plans. And MOH also will carry out inspections months ahead of the license being expired, or months after if you have most of your documentations in place. Okay, so MOH may get in touch with you to arrange an inspection date for your clinic, and we'll work out the arrangement with you. The inspection may be in person or in video inspection by Teams video call. And we do this to reduce regulatory burden for the licensees as well as the inspectors and enhance efficiency of the licensing process. So like I mentioned, Chinese New Year, mid of February. If you want to deconflict all the rush, you have December to rush out. If you are thinking about 2 months lead time to apply for your license, you may want to plan to submit in October. Then you have time to also travel with your loved ones in December, and January focus on sending kids to school, and February will fly past very fast because of Chinese New Year, right? Yeah. Next slide. So here's an overview of the licensing application process, right to the point where you receive your license. So we will walk through this, starting with the left. The application is via the help website. And once you go in using SingPass or CorpPass, then you can follow these steps. You select the type of licenses that you want to apply. Then you key in the details about your clinic, yourself, or any appointed personnel that support your business. Attach the supporting documents like your SMC certification, your laser licenses, etc. And submit your application and pay the fees. It will be guided by the help website, and complete the self-assessment checklist that's in the website itself. Then the next step, do allow the MOH admin staff to go through all your paperwork. And then once everything is cleared, the file will come to our inspectors. So do allow some time for the file to come to the inspectors. So the person who contact you in the beginning may not be the person who come and inspect your clinic. Yeah? Okay. So the inspector will contact you by email and then confirm a date for inspection that is workable for your business, your practice, because sometimes you may have certain days that you're super busy or your key personnel may not be in town, or unless you already have very seasoned clinic manager or clinic assistant who can stand in for most of the inspection except for the clinical sections. Okay, so make sure that all your documents are in place, especially SMC certification, MOM certificate for your autoclave, NEA license for some of your equipment, could be ultrasound, could be lasers if you have lasers. Okay, licenses should check for clinic readiness. It includes SOPs, and if it's a new clinic or you are refurbishing your clinic, make sure you allow enough time for the renovation to be complete. Because when we come, it has to be operationally ready. Yeah, it cannot be a place that is quite dangerous for patients to walk through. And inspectors shall email you, like I mentioned, and then once the date is fixed, then you can work towards the inspection proper. And if in the event that you have some licenses that are important, but you know that it has lapsed or maybe overlook applying it because in the past years, we know we have COVID challenges and we have our focus elsewhere, this is the time to catch up. Try to check that all your licenses are renewed, or if you have any license to apply, do apply, because with NEA and MOM, they also have a different set of timelines, a turnaround time. So now we arrive at day 0 of the inspection. We prepare so that there are documents review as a part, and the second part is the physical inspection, which is for your premises, and sometimes if the clinic is like a known clinic and it has been moving smoothly for the past years, no complaints, no hiccups, you don't have any challenges that you face from patients, then sometimes the inspection can be by video inspection. I think some of you have experienced it, especially during the COVID period, right? Yeah, and then next, after the inspection, within a few days, MOH will recap the findings that may have been found in the clinic inspection. Because before we leave the clinic, we will give a summary of what we observed and some advice. And we try not to be too strict. So we give a recap first, and then all this recap will be captured in an email to advise you on what to catch up. Anything that is missing, like maybe expired gloves that you need to throw away, PPE insufficient for your 5 staff, for example, for 1 week, then we advise you to catch up. So after all these are met, then do allow 5 to 7 days for us to process the license proper, right? And then the next step is if everything is in place, the license comes to you, you will receive an email from us, and then you can go back into help system to download your license. So far so good. So at the bottom, I would like to remind as well, the bottom there's a timeline. D80 means 6 months ahead of expiry if you're aiming to avoid expiry. D60 is 2 months, which is what we usually put in the website. D0 is the inspection itself, and then D+7 is after that. Okay, next. Yeah, so now we are talking about the licensee role when preparing to submit the application. So some of it I've already touched, that new licensees will need to submit all these documents in the help system, right? For example, proof of authorization, you're authorizing your clinic manager to do all the submissions on your behalf. ACRA BIS file to show your business profile, and professional qualification certification of the CGO and the practicing doctor in the clinic, and GFA approval from URA if your clinic is not sited in the HDB area or hospital premises. So far so good? Yeah. Okay, and then for existing clinics going through renewal, it's about the same, but you don't need to declare the GFA anymore. And you need to check that your relevant license from NEA or MOM are valid, not expired, and they should reflect the current clinic location, the current address, and SMC certs as well. Do download. Yes. Next slide. On inspection day, like I mentioned, it will be broken down to document review as well as a physical inspection. The inspection can be hosted by the CGO or the doctor, the resident doctor or clinic staff like the clinic manager or clinic assistant. And do prepare SMC certification, professional certificate or competency. Later I'll touch on that a bit. Training and competency records of your staff and yourself if relevant. And the certs like I mentioned, SOP and price list. That is going to be shown in the prominent place for patients to refer to if needed. Physical inspection, there's a list below. One segment is, of course, equipment. Make sure that the equipment are well maintained according to manufacturer's specification. And they can be autoclave, ultrasound, laser, X-ray, or some of you may even have an AED machine. Yeah, I recall working in one clinic that has one. Yes. And we will also inspect these key items like simple in vitro devices, or they use the short-term IVDs, emergency kit, medication fridge, sharps and biohazard disposal plan, PPE, like I mentioned, medications management, and clinical notes management. That includes secure filing, PDPA concerns as well. Next. So dwelling on the NEA license, these are some examples of the website that you can get the information. The QR code, you can use your phone now to even scan it and access the website. There's the ultrasound or lasers that are common in clinics. In some clinics, they may even have an X-ray. Yes. Next slide. Yeah. Okay. Hold on. Yeah. We have this MOM certificate required for our autoclaves as well. This will need about a few weeks to a month to apply for. Make sure that all the equipment specifications are provided to MOM. And you may also have friends who are running dental clinics. For dental clinics, the air receiver, which is the first item on the list, is also applicable with MOM. Next slide. Yes, clinic equipment, I've covered a bit just now. So for ultrasound laser X-ray machines, you can apply through the Go Business website. Even checking the status of whether the license is valid, you just go there and then you can do a screenshot on your phone, and that is valid to show to the inspectors. And for autoclaves, you can go to the MOM website, also renewable yearly, and some people may opt to renew 2 yearly. On the bottom right corner is an example of calibration guidelines when you are using IVD, because some equipment need the equipment to be calibrated so that you are doing accurate tests for your patients, right? So take a look at it. Next slide. And yes, the famous emergency kit. So yes. Yeah, so MOH website has this list of the drugs that you need to store. Yeah, and aside from that, some clinics may choose to store a bit more if they give mild sedation. They want to have an antidote. So you need to customize to your service as well. And on the right, you can see an example of a kit. There is an ambu bag inside with the mask and the spacer and the tubing. Currently, some suppliers do provide kits that have an expiry date. So be mindful when you buy the new sets. Don't just throw away. Take a note of all the labeling that is on the set itself or on the plastic bag wrapping the set. And then if you think that you need to change the wrapping already, it looks so grubby, you can actually maybe use a labeler, a label maker or something to label the dates onto the physical item itself. But nowadays, we can also take a photo of the label itself, just for posterity. Okay, and if you look at the bottom of the slide, there's a reminder as well. When you buy inhaled bronchodilator, the type of nebulizer that you buy in the market, do remember to have the spacer available if that set requires it. And for aero chambers, also check that if you open this aero chamber in January, within the 12 months after use, do throw it away. Okay, get a new one. And lastly, a checklist will be good to help the clinic staff so that they know what they're doing. They can keep track of when they check and what are the items that is near expiry, and then they can replace as needed. Okay, next slide. Here, cold chain. Yeah, Dr. Wong mentioned about nice fruits and drinks in the fridge. Yeah, our inspectors do encounter these surprises as well when we come to your clinic. We encourage to have a nice clean fridge, because sometimes when we put perishable items in the fridge, and worse if it's crowded, one thing you can't manage an inventory well, the temperature is not reliable, and you're worried about the cleanliness of the drugs that you provide to patients lah. So in our simple image, we have different types of fridge thermometers. We encourage to put it in the center of the fridge, not at the door where it's swing open and close quite often every day. And same for your vaccines and things like Botox, you need to put in the center of the fridge. And here's also an example of the carrier, the containers that is insulated. You may want to supplement by adding ice packs in the event that you need to transport your supplies to another location when there's a power outage in your clinic, right? Next slide. And just now I mentioned about certificate of competence. In the area of providing aesthetic care, could be lasers, could be Botox fillers. Our doctors will need to apply for the right training. There are some institutions that is supported. So you can use, there's one school mentioned at ADEC as well. So go through the training, because all these guidelines are under the ambit of SMC 2016 guidelines on aesthetic practice for doctors. Do have all your COCs in place and make sure that they are all valid. And the aesthetic practice oversight committee will also play a part in the oversight of your practices. Next slide. Almost to the last of preparation already. Our inspectors do ask for signages of new clinics to provide at least a mock-up of the sign for the clinic, for the inspectors, especially if your clinic is new, and to display the clinic charges in a prominent location. Patient management system, that means the CMS, the clinic software, the collaterals that is generated by the CMS should show the clinic logo, address, and phone number or email, so that the patient or even the insurance service providers can get back to you if they have any clarification, any doubts. Yeah. So this kind of collateral includes patient bill, medical certificates, drug labels. And we also need to make sure there's a system to ensure traceability of specimen when we send specimens to our partner lab service providers, so that the patients will get accurate and timely results. Yes. And we also want to make sure there's sufficient stockpile of PPE for 7 days of all clinic personnel in the form of disposable gowns, N95 masks, and exam gloves, for example. Next. Okay, SOPs. Well, this looked like quite a busy slide, but basically is to make sure that we give quality, safe service, and so that there's accountability for every person who is working in your clinic. There's traceability also in case there's any negative feedback or doubt that whether you provide complete care to patient A versus patient B. You can go back to your SOPs and review the steps that you've taken. And knowledge preservation as well, because sometimes we have staff that turnover, they may have left for certain reasons, family needs, etc. And you want to make sure that everyone knows what to do from the time that they step into the clinic to the time that they go home, right? So we propose 8 topics for you to prepare your SOPs. The first 6 are for the regular clinics, like preparing and dispensing administration of medicine, etc. Precaution to take to avoid contamination and degradation of specimens, for example. Yeah. Whereas if you zoom down to the bottom two, these are if you are providing temp premises services, right? Or telemedicine. I'll just pause a while so that you can have a read.
So this is the money slide. You should take a screen capture or a photo if you want, but the slides will also be made available. But this is the money slide. This is the one you should save at your desktop as a screensaver.
Okay, next slide. Okay, so we also mentioned about staff training. There's actually a regulation mentioning it because we stress the importance of making sure that our staff, our clinic staff, could be an assistant, could be a cleaner, could be a clinic manager, they are well equipped to do the job well, to support you well. So we want to make sure there's consistency and quality standard in the clinic, accountability again, and knowledge preservation. So examples of SOPs that you may want to prepare are on staff onboarding, new staff. They may come from different walks of life. Not many of them may have a clinic assistant experience, for example. And competency in handling certain key devices in the clinic, dispensing of medication, again, and assisting in a medical emergency, where to get things, where are they stored and how to help you, right? Thank you. So next slide. So we thought to spend a minute on this remote MOSD, which is actually to do telehealth with your patients. We like to stress that besides the platform for doing telehealth, the service encompasses telephone call, text message, internet-based video, or email as well. Yeah. Again, have a quick scan through of what you need to do. Basically, these points are covered when you attend the telemedicine course with MOH. So we urge those who are planning to offer this service in the months to come, do attend the course. Then you'll get a cert as well that we will inspect during our inspection. Next slide. So now we arrive at post-inspection. Just now, you remember the diagram that we went through? Post-inspection, the officers have given their recap, some advice, and then we are going to leave the premise, right? Our inspectors will send a list of follow-up items. Some of you may have very little, some may have 3 or 4, and it'll be in the form of an email. If unsure, you can write back, or you can even have a phone call after that with them. And do meet all these requirements fast, and then get back to us with your rectification as soon as possible. Because after we receive all your rectification with proof of email and photos, then we'll start processing your new license. It will take 5 to 7 days for the turnaround time. So on the right side, you can see already timeline guide, D0 plus 7. But if there are many rectifications and many hurdles to go through, sometimes it can stretch until D21, right? So be prepared. Yeah. So the best way is actually to prepare upstream. When you're already planning to renew your license or open a brand new clinic, we already plan the grand opening and all that. Plan upstream 2 to 6 months before the inspection day. Okay. And there are some possible examples of the cost delay in the rectification. For example, licensee wasn't aware that they need to apply for a specified service approval with MOH. Like I mentioned, it could be the treadmill service earlier on, right? And then absence of resus drugs, PPE stock, biohazard disposal containers for sharps, etc. But point number 2 can be quite fast. Yeah, it's easy to get. We have many suppliers to provide this. Absence of key licenses needing urgent procurement, like your N2 license, right? Or even their telehealth, if you feel that you want to apply tomorrow, right? And clinic X-ray machine and room pending NEA license. This one also take a long time. This is usually inspected by our partner inspectors, not directly by us, but I thought to mention this because it involves infrastructure. Infrastructure takes time. And for remote MOSD, licensee may be delayed in obtaining the telemedicine e-training class certification, or sometimes for new licensees, they may not have enough guidance or insight to make sure that these 4 points are reflected in the website, your clinic website: the business name, the clinic contact details, information to notify patient that the clinic is licensed by MOH to provide remote OMS service, and to also inform patient that teleconsult is not for medical emergencies, it's only for more stable cases. Next slide. And post-inspection, to manage your expectation as well, we do need 5 to 7 days after all rectifications are done. Application process is by our team only. So we also have very set standardized benchmark for clinics, and we urge licensees to focus on meeting the licensing requirements quickly, as MOH need to receive the evidence of all rectifications done. Do avoid going sending us chasers through different means, right? Because eventually all the chasers still come back to our department. So with many chasers, actually it will slow down the process further. Okay, next slide. Okay, just to recap again, we went through all these steps with you. We propose to get ready early, 2 to 6 months ahead of your expiry date or your intended grand opening for your clinic. Plan ahead, prepare ahead. And then after that, we need some time to clear all your rectifications. And then eventually you will receive a notification from us to download your license. And then lastly, next slide. Yeah, we also have like a quick checklist, you know, like a reminder, have I done this, have I done that? So for example, as services, am I providing specified services like treadmill? I should include in my help application, for example. Am I providing any form of examination, assessment, and medical advice over remote means? Then what should you do? So the list goes on, but it's actually a recap of what we have shared earlier today. Have a look.
Once again, this is a money slide. Strongly encourage everyone to take a screen capture. But once again, I will reiterate that the PowerPoint as well as the recording will be made available to you, but this is the money slide.
So do note that it's not 100% foolproof and comprehensive, because you do need to customize to your practice as well. Yeah. So point number 6, we also reminded again, don't put food and drinks in the fridge. Okay. Done? Okay, next slide. So yeah, that's all we have for sharing today. And should you have any inquiries, you can reach us on this email. Thank you.
Thank you, Caroline, for a very good talk. I noticed that Q&A has been coming in, and our MOH team has been replying. So if you have any questions, you can type into the Q&A function, and they'll try our best to reply. And there is a FAQ. Sorry, there's another Q&A discussion later. The panelists. Okay. Next up, we have Dr. Suraj Kumar. Who, next slide, please. My slide. Yeah. Chester, share screen, please. Yes. Next slide. Okay, next we have Dr. Suraj Kumar, who is the Vice President of College, who will take us through the launch of the new Clean Resuscitation Drugs and Equipment Training module. Just to emphasize, Dr. Suraj is giving out key features and learning points of the module. The module is very comprehensive. We urge everyone to go into our WizLearn to download the slides and look through and read through it carefully, and do attempt the MCQ on the resuscitation drugs so you can get additional CME points. I would like to hand the time now to Dr. Suraj. Dr. Suraj, thank you.
Okay, thanks, Nelson. Just let me share my screen. Okay. Hi, everyone. Nelson, you can see my slides, right? Yeah.
Yes, it's very good. Thank you.
Okay. Right. Hi, everyone. Okay. As Nelson mentioned, I'm here to do the section to introduce the module on the use and administration of resuscitation drugs and resuscitation equipment as required under the licensing guideline and with the licensing requirements. So as Nelson mentioned, I'm not here to give a lecture actually, because the slides are actually full of content. They're very detailed, quite detailed and wordy a bit. So these slides will be put on our WizLearn website, where you can actually view them and download them on at your own time. And you can also attempt the MCQs that will be on the WizLearn. so that you can get an extra CME point of 1 point, in addition to the 2 points you received for the webinar today. Right, so I'm going to start off by a quick introduction, but before I do that, I would like to thank my work group who helped me a lot. There were various representatives from the polyclinic clusters as well as private sector GPs. Okay, so what we will do today is go through the introduction first, right? Just to recap, certain emergency drugs and equipment are required to be kept in the clinic under licensing guidelines, right? But as I will explain later in the next few slides, if you look at the drugs that are required and the equipment is required, it's mainly for the management of anaphylaxis and severe allergic reactions in the clinic setting. So the main objective of this module is actually to become familiar with how to use these drugs and equipment and in the management of anaphylaxis. This module actually doesn't cover cardiopulmonary resuscitation. Cardiopulmonary resuscitation in the clinic setting will actually be a BCLS and AED. So actually all medical practitioners are encouraged to be proficient and current in BCLS AED techniques and the use of the equipment, right? And I think in future, it might be necessary for all of us to attend this type of courses. And if you do stop certain drugs which are outside the MOH list for licensing, in other words, if you have special drugs like cardiac drugs, for example, if you run treadmill services, you might be stocking as a requirement lignocaine, atropine, and some clinics might choose to keep adenosine for SVT treatment. If you want to keep these drugs, then actually the licensee should ensure that the staff are familiar using these drugs, right, properly and in the correct dosages and indications. And this usually requires further training, but that's an individual preference or choice. Okay, so the module outline actually is very simple. I'll run through the list, right? And then we go into the management of anaphylaxis in adults and some special groups such as children and pregnancy. And finally, rounding off with the how to use the resuscitation equipment. So coming to the drugs, as I mentioned, these drugs are mainly for the management of anaphylaxis. If you take one look, you know that 4 drugs basically need to be kept. Injection adrenaline is the most important one. And please note that the dosage, the strength of the drug or the dilution is 1 in 1,000, not 1 in 10,000. 1 in 10,000 is actually used for cardiopulmonary resuscitation and delivered intravenous, whereas 1 in 1,000 is usually used for allergy management and is delivered intramuscular as an emergency. In addition to that, you also require to keep an antihistamine and a steroid, usually hydrocortisone, as well as a bronchodilator in the inhaled form. It can be salbutamol or atrovan. And so these are the 4 drugs that are required to be kept as a licensing requirement. The equipment, as already alluded to in the previous talk by our MOH speaker, you need to keep a bag of masks, which are commonly known as an ambu bag. Airway sizes must be at least 2 types, usually a pediatric and adult size. And you must have an infusion or IV set, right, together with the various solutions and the cannulas that are needed. For bronchodilators, you need delivery devices, right? Either aero chamber. Oxygen is not compulsory, but can be kept optionally. So let's deep dive into anaphylaxis in adults. And of course, everybody associates, this picture shows that what we all associate with anaphylaxis, giving an EpiPen injection into your thigh. But actually, the management is a little bit more than that. And first, we have to assess the signs and symptoms. And it cannot always be quite straightforward, because there are multitude of signs and symptoms that can happen in allergy and severe anaphylaxis. So we allude or refer to the World Allergy Organization grading system. And this is quite a busy slide, but you can look through this at your own time on the Wisland website, right? Just know that there are 4 grades, grade 1 to grade 5. And generally grade 1 or grade 2, which are milder in terms of symptoms, are not recognized as anaphylaxis, whereas grade 3, 4, and 5 is considered anaphylaxis. And of course, the grades progress in terms of severity, ranging from bronchospasm in grade 3 right up to cardiovascular collapse and respiratory compromise in grade 5. Right? So this is for reference. Just bear in mind this. And then when we come to assessment of signs and symptoms, early symptoms can be respiratory or in the chest or in the skin. And bear in mind, it can also be in the gut, right? Symptoms of severe allergy. And again, we reference back to the table where we will try to see that they fit into grade 3, 4, 5, or you to suspect that this might be a case of anaphylaxis. And Don't forget the red flags. You need to watch out for red flags. In other words, rapid progression of symptoms, respiratory distress, and severe GIT symptoms can also indicate that the collapse is impending. Of course, the classical hypotension, chest pain, and collapse. Right? Death from anaphylaxis, which we hope never occurs, usually results from asphyxiation of the upper and lower airways, obstruction. It can also occur from cardiovascular collapse. So we come back, after assessing the signs and symptoms, we come back to the criteria for anaphylaxis. What makes you suspect that anaphylaxis is highly likely? So you have two criteria, either A or B, right? In A, you have an onset of an illness that's rapidly progressive with skin symptoms, mucosal changes, and the usual other symptoms of the skin, in conjunction with at least one of the following, which is respiratory compromise or hypotension or GIT symptoms. Or you can use B as a criteria where you have hypotension and bronchospasm. Need not necessarily have skin symptoms, but you would have a known allergen that you suspect, right? So it can be A or B for you to fulfill the criteria of anaphylaxis. Once you have done that and you strongly suspect anaphylaxis, you can, if the patient is stable, of course, you can go into additional history, right, which will be supportive of your diagnosis. But this is only if the patient is stable and not deteriorating, right? And this is quite straightforward. It's quite obvious that you also need to take a drug history and underlying medical conditions if you have the time. But always be aware of the pitfalls. Anaphylaxis can be very diverse in its presentation and non-specific. And because it is uncommon, we don't often suspect it, but you need a high index of suspicion, right? Skin symptoms and hypotension might be absent, right? Especially hypotension might be masked by compensatory mechanisms, right? And sometimes bronchospasm in anaphylaxis is mistaken to be an asthma attack, right? And that can lead to dire consequences if it's not recognized and managed properly. So if there's diagnostic difficulty, always be aware of or be highly suspicious of life-threatening conditions and the symptoms that go with it. So this must be recognized and immediate action taken. And the immediate action or the immediate treatment, of course, first of all, you start off with your ABCDE, followed by call 995. And if you know the allergen is present, please remove it. And some positioning is required if the patient is hypotensive and having impending collapse. But most importantly, at the same time, you should administer adrenaline, again, done concurrently to the immediate measures or just after it. I will go through it in the next slide. But other supportive measures will be oxygen if you do stop oxygen in the clinic. Respiratory and circulatory support is where your ambu bag and your IV infusion set come in. And that will include fluid resuscitation. And finally, CPR. We hope that it never comes to this because this means the patient is collapsed. But this emphasizes the importance of being trained in BCLS and AED, regardless of whether it's an allergy or actual cardiovascular reasons. So coming to adrenaline, intramuscular adrenaline is the first line of anaphylaxis. Early use is very important as part of the immediate measures. Now, of course, you might have to be cautious in patients with known CAD and other risk factors like hypovolemia and thyroid disease. But just remember that there is no absolute contraindication to IM adrenaline in the setting of anaphylaxis because anaphylaxis is life-threatening and adrenaline is life-saving. So the dosages are listed here. It can be maximum 0.5, but usually the pens contain 0.3 milligrams per dose, right? And avoid IV adrenaline. That is only reserved for cardiovascular resuscitation in dilution of 1 in 10,000, right? Usually done in a hospital or an ED setting. Just be aware of the side effects. And the injection is usually given in the vastus lateralis of the thigh, right? The lateral part of the thigh. There is also adjunct therapy. Now, the proviso is that adjunct therapy does not replace immediate management. It cannot be used as standalone, right? Or substitute for the immediate measures, which includes IV adrenaline. But the adjunct therapy is where your antihistamine and your steroids come in. I won't go through the dosages. It's all listed here for you to go through in your own time. But antihistamines, of course, take care of allergy symptoms. And hydrocort is important for the delayed reaction, which I'll go through later, the delayed reaction or biphasic reactions. So it's important to give steroids quite early. And part of the adjunct therapy is also circulatory support through IV infusion and bronchodilators if there's bronchospasm, right? Again, I won't go through all the details here. Monitoring is very important. You got to monitor the vital signs, right? Of course, you hope that you don't need to do CPR, but you must be prepared to do CPR if necessary. But the most important thing is that if you have diagnosed anaphylaxis and strongly suspect anaphylaxis, or it fulfills the criteria, patients must be sent to A&E, not treated as outpatients and sent home, even if the symptoms are suspected to be mild, right? The observation period actually stretches a long time, 8 to 12 hours, which is why you need to refer them, right? This is because sometimes you can have a relapse of the reaction and what we call a biphasic anaphylaxis. In other words, they improve, but later on they get a recurrence of symptoms and possibly even cardiovascular collapse, which is why they need to have steroids initiated quite early. So this is an overview, a busy slide, but simple. First thing, you need to analyze the symptoms and decide whether they fulfill the criteria for anaphylaxis, after which you immediately go into your ABCD, calling the ambulance, putting in your adrenaline, and then employing the adjunct measures, and finally sending them off in the ambulance, right? So this is the overview of management. Now, what about special groups? You've also got children, right? Generally, children considered less than 12 years, right? So generally, this picture says it all, right? Again, here, note that the EpiPen is actually meant for children. This is a junior EpiPen, which means that your adrenaline dosage is lower. But generally, everything else is the same as for adults, except bear in mind that the symptoms of hypotension can be different in adults and children, as this table will show. And this table we put up in the website as well for you as a reference for yourself, right? And also bear in mind that symptoms can be non-specific in children, such as a change in voice, lethargy, or even agitation. Now, of course, you would have to monitor their vital signs, again, according to the chart of symptoms appropriate for age. Immediate management is not different from adults. ABCDE 995, position the patient and give your adrenaline early. And the dosage of adrenaline, I will show in the next slide, will be appropriate for weight or age. So you need IV access, but of course, IV access in pediatric patients is not always easy, but we will still try. And so you must have a set available. And of course, the other support in terms of oxygen if present, and you stand by to do CPR if necessary. Bag and mask as well. Right. So the medication here again is first line is adrenaline, same concentration, but the dosaging is different. Right. Never use IV adrenaline. Now bear in mind, in adults and in children, you might need more than one dose of adrenaline. So sometimes you need to repeat the adrenaline every 5 or 15 minutes, depending on the clinical response. Right, so this is a chart that shows you the weight, the dosage of the adrenaline according to weight, right? And generally you find more than 0.3 is already adult dose. And again, adjunct are the same, hydrocort, antihistamine, and again, the dosages are here for as a reference point for you. Sometimes if you cannot deliver the IV antihistamine, you can give it orally, and again, delivery of the bronchodilator through a device, appropriate device. Other special group that you should pay attention to are pregnancy. In pregnant women, they will have the same symptoms as normal non-pregnant adults. But bear in mind, you can have other symptoms as well, like vulvar itching, low back pain, uterine cramps, and there's always a risk of preterm labor and fetal distress in pregnancy. So you need to watch out for this in this special group. Otherwise, the treatment is roughly the same, ABCDE, calling 995, but the position you place the patient is a bit different. Right, you need to place them on the left lateral position. The other methods of treatment is roughly the same, right? Delivery of oxygen, IV access, and so on. The adrenaline is also delivered in the same dose, and so too are the adjuncts of the steroid and the antihistamines, and the bronchodilators. So that brings us quickly to the resuscitation equipment itself. We've gone through the drugs, now the equipment. Just to recap, bag and mask, airways, infusion set, and the delivery device for your bronchodilators. So coming to the ambu bag, I think this one was shown just now by my preceding speaker. And you can actually buy a set, and you pay attention to the expiry date. It becomes packed up in a bag. So the expiry date is very important if you are already purchasing as one set. And usually they sell the set in the terms of an ambu bag, the bag itself. Mask will come in 2 sizes, usually adult and a pediatric size. It might have airways in the set. I'll go through the airways a little bit in the next slide. right? But know that the ambu bag is very important because it actually delivers positive pressure ventilation. And it's usually done in patients who are having breathing difficulty, inadequate breathing, or have stopped breathing altogether. In other words, it is part of your set to be used in CPR. Right? In CPR, you will also use an ambu bag to deliver the breathing in addition to the cardiac compressions. Just know that the oxygen, this is important because it actually delivers a higher percentage of oxygen even in room air as compared to normal rescue breathing. Of course, if you connect it to oxygen, the percentage increases. So how to use the ambu bag, right? You need to have select the correct size of the mask. Positioning of the airway is also important. Now, there's a little bit of difference, as this diagram shows, a bit of difference in adults and children. In adults, of course, a classic chin lift so that you can straighten out the airway. But in children, you don't hyperextend, overextend, or underextend. So it's a little bit more neutral in terms of the extension of the hip. And placing the ambu bag itself, I won't go through the details. You can use both hands, your non-dominant and dominant hand, and how you place the fingers. You can go through this in your own time. But basically, you hold the bag, hold the mask in place with one hand, and then squeeze the bag with your dominant hand, right? And then observe whether the chest rises and falls in the patient's color, whether your bag and mask is effective. Coming to the airways, as mentioned, there are two sizes. Generally, you can measure the size by placing the airway as such in this diagram. And airways come in many sizes, but I think you need to stock at least two airways, right? A pediatric one and an adult one. So this would probably be the child, which is the black, and the adult, which is the green one, right? The rest are variable sizes. It depends on whether you purchase a whole list of airways, but you must have a minimum of at least two airways, one for pediatric, one for adult. And this is how, to recap your undergrad days, if you were taught this, how to place an airway is to insert it in one way, twist it around, and then position it in the final correct way, right? Now, IV infusion, of course, we are all familiar with you need to stock minimum of a normal saline acid crystalloid, right? And this is where you use it in hypotensive or cardiovascular collapse, right? And you need an IV set. Of course, now it's easily available from your supplier, right? Just bear in mind that the cannulas come in different sizes, and the teaching is that if you set up an IV line in a patient who's hypotensive, you want a large bore cannula, and you run the infusion at a maximum rate. And this gives you an idea of the rate and the size of the cannulas, right? Generally, you would use probably a minimum of a green size, right? And if you want an orange cannula, but bear in mind, the larger the bore of the cannula, it might be difficult to do an IV insertion because of the collapsed veins. So sometimes you have to use your judgment and keep a series of cannulas available for you to access the veins. Coming to the aero chamber, if there's wheezing, then you might want to deliver a bronchodilator, and the bronchodilators have to be delivered through an inhale mechanism, right? And so usually use an aero chamber or a spacer. You can also, many clinics also have nebulizers. You can also use a nebulizer to drive the bronchodilator in. And the dosages are all here, and how you would fill up the aero chamber is also listed here in terms of the bronchodilator, right? And if available, you can use oxygen. And not every clinic is required to have oxygen, but if you do keep oxygen in your clinic, just make sure you maintain it properly. And the most important thing is you've got to make sure there's enough oxygen in the cylinder, in the tank, and you've always got to check the levels. Otherwise, in an emergency situation and the tank is empty, then your oxygen becomes useless, right? You can deliver it through the face mask or a non-rebreather mask as depicted in the diagram, right? So I've come to the end of the talk. Must stress that all that I did for you, I ran through very fast, but all the information will be available on the WISLearn and our website in the WISLearn e-learning platform in the college website. You can go through it at your own time. You can attempt the MCQs, and the content will be available for a long period. So please read through and be familiar with how to use emergency drugs and emergency equipment. Thank you.
Thank you, Dr. Suraj. We know that some of you may not be able to access WISLearn, so we will make available the slides on our website as well. We also thank the Ministry of Health for providing us a clean version of the website to upload for all of you to look. And again, I want to reiterate that the video recording of this webinar is also available on our website. You can also refresh. We now move to the Q&A section, which is the most interesting. I would like to start first with the most common mistake and breaches. So as a matter of open disclosure, Dr. Suraj, Dr. Wong is also part of the audit team. So they also go on the clinic. So I would like to invite each of the speaker to list and name one common mistake that you see, right? We'll start with our lead speaker, Miss Caroline. What is the most common mistake you have noticed? Caroline, are you there? Yeah. You have to unmute yourself, Caroline. Thank you. Yeah. Why don't you share one common mistake that you often see as a veteran auditor?
Not preparing on time for the inspection.
Okay, that means
Yeah.
last minute, then try to get everything, is it?
Yes.
Okay, that's your most common mistake. Okay, next
Yes.
up, Dr. Wong Tianhua, having inspected the more troublesome clinics, what is a common mistake that you see we would like to share with our audience?
I
I'm
think,
going down the line.
yeah,
Everybody must give one.
all right. Probably the expiry dates of small items that you don't think there will be. For example, all your IV cannulas or your needles, injections. You tend to leave them around, and if you don't look at them over a period of time, then the expiry date is exceeded. So that's quite common.
Yeah. Next, I would like to invite the head of the MOH inspection team, Ms. Jahara, to share one of her common breaches or mistakes. Breaches or mistakes, could be either one. Yeah.
Hang on. Okay, so can you hear me?
Yes, we can. Thank you for joining us, taking time out.
Can you hear?
Yes, we can.
Yeah.
Thank you.
So I think there's a few things that we do see coming up quite often. Mistakes that clinics make, I think, to prepare for renewal or new application. I think the biggest one we see a lot is NEA licenses, MOM certifications that you need to have before we can actually issue you with a license where you need to use any of the equipment that require any of these licenses. I suppose the other one is your expiration date of your e-kit. You got to check and you got to make sure. And we do see a lot of people actually have expired e-kit equipment or supplies. PPEs are important. So make sure that you have PPEs, enough PPEs for people in your clinic, and then they are not expired. Okay, I think I've said too much. Probably I pass on to Nelson to pick someone else.
Okay, that's a good one. Okay, let's go out down the line. My favorite group, Kang Xie. What do you, as a seasoned veteran auditor, what do you see very often? Cannot repeat, So as we go down the line, it gets more difficult.
Hello. Yeah, so I think one of the other issues we actually see commonly, I think quite a lot of our doctor friends perform aesthetics procedures. So as what Caroline mentioned just now in her speech, that there is a need for certain aesthetic procedures to have certificates of competencies. So sometimes we don't see everybody with these certificates. Thank you.
Any particular one they're often missing? I think the Botox one they always have it. Is it they're missing some like the skin tightening one?
Botox, chemical peels, lasers, fillers. Yeah, just to make sure whichever procedure you are doing that you have the corresponding COCs.
And if possible, try to get every single COC on standby, right?
If you have the intention to do the procedure, then it's better to have the COC ready instead of when you want to start the procedure, then you realize you don't have the COC that you.
Okay, how about Grace? Grace, what do you often see?
Hello, I'm in the same room with Kang Jie. So I think
Okay.
a lot of times we also see issues with the temperature monitoring of the vaccine fridge. You need to monitor it twice a day, and no food and drinks, as we actually mentioned earlier.
Okay.
Thank you.
Right. So just to reiterate, I think a lot of the key things is relating to expired stock, and some sort of suboptimal clinical practices or lack of preparation. So we strongly encourage that you follow what they recommend in the slides, which is to use the time before the inspection to do some sort of like cleanup and sort of housekeeping and tidying up and preparing the key paperwork like the SOPs, the certificates, the telemedicine, the aesthetic procedure certificates, and the various certificates and licensing ready so that you can have a smooth and fast. And in general, if you are well prepared, the inspection is very fast. We have seen before less than 1 hour, so they can wrap up. So the key is advanced preparation. So we hope through this webinar, we highlight to you what are the key mistakes, common things that have occurred, and then what are the things to look out for, right? Okay, next, I want to talk about the adrenaline question, right? So there's a question about what if they made a wrong diagnosis and they gave the IM adrenaline.
Yeah,
Dr. Suraj, is it better to just give if in doubt or don't give?
Okay, so this is my own clinic. I mean, I'm not an expert, but this is our clinical experience. So that's why I stress on the signs and symptoms and trying to assess whether it's anaphylaxis accurately. But if you suspect anaphylaxis, then you should err on the side of, I mean, you should be looking at the risk-benefit analysis. So in other words, the benefit will outweigh the risk, and it should be all right to administer adrenaline, provided you're convinced you're dealing with an anaphylaxis patient. And this is in patients who are cardiovascular, have a good cardiovascular stability. Those with high risk cardiovascular background, you might have to be more cautious. But again, if you suspect that the patient, or you apply the criteria that I just listed out, and you feel that it's strongly convincing that the patient has anaphylaxis, don't waste time. You should administer the adrenaline, monitor the vital signs after that closely, right? It should be safe. Whether you should give a second injection or a third injection, all that depends on the response, right? So sometimes one injection is enough, sometimes you might need to give a second one, but you should be monitoring the vital signs all the way.
All right. So
Right.
in essence, right, it is better to give than to not to give because this is IM adrenaline, not IV. So the actual downside is less. But if you delay the administration of a adrenaline, you could potentially miss the window to save the patient's life. So because anaphylaxis is a acute emergency, and the patient can deteriorate very rapidly, right? If you have clinical suspicion, it is always err on the side of caution and just administer the adrenaline. Even if it turned out subsequently not to be, it was just a severe allergy, you will not have done more harm than had you withheld it if it turned out to be anaphylaxis. I think that's the golden thing. I think the other question is, they say that does all anaphylaxis needs to be referred to the A&E? What are your thoughts, Dr. Suraj?
Yes, so again, I emphasize that if you suspect anaphylaxis, you should refer to A&E, if necessary, call an ambulance, because if you ask the patient to go himself, first of all, the patient might not go. Secondly, they might take a long time to go there. And as I mentioned, the danger of a recurrent reaction or a biphasic reaction, the risk is very real. It does happen, right? The patient can collapse even a few hours after the initial so-called success of your adrenaline, because adrenaline only addresses the immediate concern of cardiovascular collapse. But the long-term changes that take place need to be addressed by the steroids and observation. So that's why the best be monitored if you send to A&E, they will monitor ED for at least half a day, Yeah.
Excellent. So the key point is that anaphylaxis, even if there's an immediate apparent response to your treatment, you still need to refer because the patient needs monitoring. The patient can relapse, right? So you cannot assume that your jabs did the job and that you can send off the patient. It is quite risky, especially if the patient is unaccompanied, stay alone, or has to travel by public transport home. So it's better in all cases of suspected anaphylaxis to activate 995 and to refer the patient to the A&E, because there needs to be continuous monitoring with more standby resuscitation on an as-needed basis. Okay. Next up, I think we must first congratulate Dr. Devian. Seems like Dr. Devian is opening a new clinic. There's a lot of new clinic questions from Dr. Devian. Take this opportunity to invite any of the MOH speakers to maybe do a run through on new clinics, right? Especially the questions about renovation and how long it takes for the inspection process, and at which point they should start applying for the inspection. May I have one of our MOH speakers to just do a run through about the new clinics? Anyone? Jahara, thank you.
Hi. So timeline for new clinics. Okay, just
Yeah.
a quick rundown, right? So we
Sure.
say in the law that actually in the regulations that you need to submit your application 2 months before your date of clinic opening. So if you think you're going to open your clinic in October, you need to submit in somewhere in 2 months, maybe September, end of September. Early September lah. So depending, August, September. why we need the 2 months is because you need to submit all the relevant documentation, all your certs and whatever that we require as part of licensing. After you have already submitted that, we will review those information, and then we will reach out to you and schedule your inspection of the clinic. After we've done the inspection, there may be rectifications, and you will need to do the rectifications before we issue a license. And as what Caroline had presented earlier, after you finish rectifications, you need another, you need to give us between 3 to 7 working days to actually approve the license. Then you can go. So this is the sequence. I think the difficulty we have seen in some clinics is that I know the list is an issue, and you will tend to come to us and say, you know, I need to have this new clinic starting, you know, I can only finish renovation 1 week before my opening. We understand all of that, but we still require that you submit 2 months before, so that we are aware that you need your license, or you need your clinic license by when. We can schedule it properly so that we can give you enough time to rectify all the changes, if there are any rectifications, before we issue the license. That is the sequence. And that's why we say it is important to come to us 2 months in advance. Don't come to us couple of weeks before you're going to open, because bear in mind that we have 11,000 licenses, more than 11,000 licenses. We process more than 2,000 in a year. Just renewals. We get new clinics, a few, like maybe 6 to 7 a week. And if everyone comes to us and say, I want my license within 1 week, and I'm going to submit now and then give me a license within 1 week, there's no way my team will be able to process all of that. And the other thing, perhaps, you know, a bit of a broken record, I think a lot of people have the speakers before me, and I said it before in previous presentations. Once you submit your application, trust that we will be looking at it, and trust that we take note on the date when you think you want to start your clinic. We will reach out to you. We'll make sure we give enough time for you to actually get inspection and to get your license. If you don't hear from us, it's good news, because means that you have submitted everything perfectly. There's no need for us to reach out to you. And there's no need, if you don't hear from us after you have submitted the application 1 week, 2 weeks, you don't hear from us, don't go chasing everyone or looking for everyone to ask whether, you know, have we looked at the application. So we will reach out to you if we need to process your application. Yeah.
Okay.
I hope I have explained it. If there's any further clarification, I'm more than happy to address.
Just to add to, they inspect every single medical facility, excluding the Singapore Armed Forces and SCDF, right? Every single, plus the prison, plus the hospital, plus the kidneys dialysis center, plus the, so they actually have a lot of work, but they will do their best to help you meet the timing of your opening. But it cannot be a ridiculous 24-hour approval, and nobody has that kind of.
Can I ask this interesting question about renovation? Can I ask MOH? So,
Sure.
Is there renovation-wise, have you seen any clinic that is so small that you have to specify that there must be a waiting area, or the consultation room is so tight that there's no bed for them to examine the abdomen? Do you look at those things as well?
We do. Actually, we do look at the layout of the clinic, but so far we have not seen a clinic where we need to ask you to re-renovate the space. Yeah, I don't think we do.
So basic things like waiting room must be there, right? There must be a registration counter. That you have to have a consult room that's closed,
I mean, you need to have a waiting room, a registration area for the patients to come and at least register and wait for the to be seen by the doctor. I do see a lot of clinics that are actually small size, but they still can manage to configure their clinic such that you have a small waiting area for your patients to come in. Yeah, so I perhaps I'm not quite clear what is the issue with the renovation that came, you know, came with that query.
Do you need to have a waiting area? Can you ask the patients to wait outside the corridor? You know, for example.
I would say this, that actually if a patient is not well, or you know, it is going to be very difficult for the patient to be standing outside your clinic. And also certain spaces like, you know, HDB area, there's not much space for the patient to wait outside in the corridor as well. So yeah, it is preferable that you have actually a space for your patients to wait.
I would say you need a waiting area because you need some privacy. You cannot be registering patient and chasing them out kind of thing. So you must have at least a 2 to 4 seater waiting area for the patient, especially unwell patients like elderly. You need them to rest them. You can't be making them stand outside exposed to the elements. So I think a waiting area is compulsory. Since Dr. Wong is here, Dr. Wong is a veteran GP, a very highly experienced, right? What your clinic layout wise, can you share whether maybe Dr. Wong can share your clinic layout, how many rooms you have and what are the key areas?
I think mine is quite old school, but we have got a treatment room and 2 consult rooms. But I'm only practicing alone. But in case, but I understand that recently, because of the rentals and all that, clinic spaces tend to be rather small nowadays and getting smaller, right? So there is a constraint in the physical spaces that we are operating in, and I think it's a reality of the business environment, you see. So I'm just wondering, how small does it have to be, I mean, I've seen some standees that, of course, those are telemedicine standees that is just one, it's electronic and all that, right? But are we at the stage where we can accept, a 200 square feet kind of area for clinic, is it?
It depends on your operations, I presume. But some areas cannot be compromised, like the fire safety, the resuscitation, where does SCDF come in? If you need to do a CPR, where do you put the patient? I think all these sort of, and the storage areas, I think all these will still have to be prioritized.
Yeah, of course. But I understand that you need to have a washing sink, right? Of course. But you don't necessarily need to have a toilet, right?
Correct. Some clinics actually don't have toilet, but if you don't have a toilet, you better have a toilet nearby because you will do a urine
Yes.
test or something. You can't expect the patient to pee in the great outdoors. So at least
Yeah.
a private area for toilet. If you are right beside in a shopping mall with a shared toilet, you need not have a toilet. You're in a shopping mall shared toilet, or you are right beside a coffee shop, have a nice toilet, then I think it's fine. So it depends on the
Yes.
setup. But bare minimum, you must have a reception area, waiting area. You must have, of course, your storage area where you store the key things, a consult room, preferably with one procedural room. But if you don't have that, a consult room must be able to configure to at least administer some sort of immediate treatment. I think that will be quite helpful. Then, Dr. Wong, please stay on the line. So you are a veteran GP and a highly respected GP. So there's this question, very interesting question about SOP and competency. I think this is a quite relatively new concept for GPs. So there were questions like, oh, my assistant has been with me for many years. Does he still need a SOP and competency? What are your thoughts about SOP and competency? How do you deliver this for your practice?
I think I think it's more to the new side of the Haksa now that is being launched. I think there's a requirement, right? In the old days, they didn't ask for those things. So we got a lot of feedback from the previous gen of family doctors who never had been required to show SOP. Suddenly they're asked to show it. So that's why one of the things that we need to come up with a list of SOP that they need to prepare. And I think it's very good that MOH is able to show us on the slides, right, what is required. So now everybody knows what is required and we can prepare them now. And it's not, I think for doctors in Singapore, as long as we know what is needed, there's no surprises. We have adequate time to prepare, we will prepare them, right? Because it's necessary. So simple things, if it's a very small operation, and there's an SOP for example, patient complaints or SOP for errors, you just have to write it down on the paper, you generate it, on a list, and put it somewhere that your staff is able to review them and everybody know where it is, and your new staff is able to see them as well. And I think that's what's the minimum requirement for SOP.
Sure. Would the college be providing any assistance?
Yes, we would like to help. And are we going to do that for the SOP?
You can decide. You are the president.
The templates.
You and the vice president. Okay, but I need to swing back to Suraj because there is some e-drug questions, quite a few e-drug questions. I need
One is administrative.
Yes.
Yeah, before I forget, the AED requirement, right? Is there a requirement for AED in the clinic?
No, not yet. Not at this moment. If you,
Jahara, when are we starting
you-
Miss Jahara, when are we starting the AED?
No, we don't
no,
need
AED
your,
won't- yeah.
you don't need AED in the clinic, but you need to
No.
know where is the nearest one.
Yes, yeah, because AEDs are very widespread now.
Yeah.
And especially the heartland clinics, you make sure you know where your AED, the nearest AED is, and your staff know. If patient collapses in your clinic, make sure one of your staff goes quickly gets the AED.
Sure. And do they need the BCRS AED cert?
Yeah. Well, Jara is.
So we will give you a sunrise, January 2027. Then we will enforce. every healthcare professional, I would say a registered healthcare professional that's in a front-facing with a patient needs a BCLS AED. For your clinic assistants, it is encouraged that you at least have them CPR AED.
Yeah.
Okay, so
Yeah.
inclusive of locums, as long as you're a doctor practicing in a clinic, you need a
Yes.
BCLS AED, right? So
Yes.
which is
So
we
Yes.
have
now they
including dentists also, they already started.
Yes.
Yeah, so the
And
dentists can do
dentists
it, you
have
can do
to,
it.
yeah, most dentists
Oh,
have to actually
high
be
risk.
BCLS. It has to be valid before they renew their PC. So,
Exactly. So I think doctors, you are being the forefront of care and primary care, especially, please have a BCLS AED. So there are many providers. They are very cost efficient. PCN also have providers. So there are many choices for BCLS AED. And those are very fast one. They are very good, very efficient, and a lot of nearby. So if you need help in contacting, do contact the PCN or college, right? Okay.
One
Okay,
more
let's
thing,
talk about
Nelson.
the e-drugs.
Sorry.
They say that very hard to buy an e-drug. Dr. Suraj, do they have to buy a whole valve of like a whole packet of adrenaline, or there are solutions for that?
Well, I can't answer. I checked with my clinic staff, but I think that is a real problem for many GPs. But I think there are suppliers that sell smaller quantities. I'm not sure about this. This one I need to check on it, and maybe the
Okay.
college check.
From my experience, there are vendors who prepare the entire e-kit for you. You can just buy the
Yes.
e-kit, all the drugs all inside. So you don't have to buy one by one, assemble yourself.
I think some of the hospital pharmacies also sell it. The e-kit where you have individual drugs and necessary requirements according to the licensing guidelines. But I just wanted to check with Jahar one more time about the CPR. One of the many questions that's going to be raised when the BCLS becomes compulsory is, are there any exemptions, especially in terms of age and medical conditions? Because a lot of people will be, as doctors get older, it is a real problem in doing CPR. In terms of musculoskeletal capability to do a CPR, cardiac massage, cardiac compressions, waiting for the ambulance to come. So something that I think you will be specifying the criteria, right, when this comes up.
Yeah.
MOH guideline.
Yeah, actually, we have already given out the circular to indicate that if you have a medical condition, but I would say you need someone to diagnose you with that medical condition, we will then actually use that as, we will allow. And BCLS has got a theory component. So even though you can't do the physical, you have to go through the theory component and show that you are actually certified and have valid certification for the theory component. Yeah, but we do accept. Yeah.
Okay, good. Okay.
Is a fire extinguisher necessary in a clinic? This is a good question. Jahara, is fire extinguishers necessary?
No.
The FSB, comes under FSB, fire and safety.
I
Right?
don't think so. It is a requirement in a clinic.
Unless you keep flammable material.
Okay, this one probably we will check for you, but the fire safety is not currently under HACSA. It's actually under SCDF. We will clarify, but whether there's a need for a fire extinguisher within the clinic. Yeah.
Yeah, but they actually have the FCDF so-called vendors there. They walk around the clinics and then they tell you that your fire extinguisher is not enough or out of date. They've done it before. Yeah.
If it's a requirement from SCDF, you have to actually comply.
I think it depends on where you are sited. Like if you're sited in a shop house, then you have a higher requirement. If you're sited in a shopping mall with a centralized fire system, then you may not need so it really depends on where you are sited and also the scope of your practice. If you have an autoclave machine, you have oxygen tank, you better have a fire extinguisher somewhere. I think you have to look carefully at the scope. But I think you're right. You do have to check back with the SCDF on the fire safety issues. More questions about the e-drug? I think that if I'm not wrong, there really is a ready-made e-kit, but I don't think MOH will be able to provide a centralized distributor of e-drugs, right? I don't think so.
I think you can also buy it at hospitals.
Yeah.
You can prescribe and then you can actually purchase it from the hospitals. And we do know certain clinics have actually been able to do that.
Yeah, I think you can write a prescription.
Yeah.
It filled out at the hospital pharmacy.
Yeah.
Drugs.
HSA stopping sales of medication in loose forms. Is that under us or is that DDGH, Raymond? There's a question about must buy 1,000. I haven't heard of 1,000
Yeah,
tablets.
so they're concerned.
HSC stock. Okay, this one, I don't know whether Raymond is in the call.
Yeah, Prof is here.
Yeah,
Yes,
otherwise
I'm
we
here,
will
but
check
I
for
think I
you.
will
Yeah.
need to check. Yeah,
Otherwise, we will check for you.
Yeah, they'll check on the loose sale
Loose
mentioned by
sales.
Dr. Vivian Chong. But if I'm not wrong, there's no such thing as secession or loose form. But usually medicines come in strips or in a bottle that's pre-packed already. So but the bottle size are not humongous one. So depending on what medicine you're referring to, we're not sure what medicine you're referring to.
Correct.
Maybe Dr. Vivian, you can share which specific medicine you're referring to. But in general, you can still purchase small quantity of medicines from selected vendors. But maybe not like 3 tablets of Panadol in loose form, but maybe like 1 strip or 10 tablet or something. But perhaps you can share with us the medication, then we'll get back to you. Okay, BCLS exemption for 60 and above, is that in the works or?
I think we already answered that. Jara has come up with
We will look at medical condition rather than age. I would
Mm.
like to think that, you know, people age differently. So some people at 60 will still be very good, and some people at 70 still can do it. But so it depends on the medical condition rather than age.
Yeah, it shouldn't be that once you hit this age, you are
Yes.
exempted from everything, right? So I think there's still a lot of people in the 60s, 70s who are very active. But of course, if you do have medical issues like you dislocated shoulder, you have a spinal lumbar stenosis or some sort of that makes CPR challenging, then please get a necessary paperwork so that can be granted an exemption for the practical component. I think that's the same practice in hospital. They do grant the exemption for the practical component for people with valid medical reasons, right? But of course, you still need to pass the theory, like you still have to do the theory. A lot of fire safety questions are over.
Actually, it comes under CDF, SCDF.
Okay, back to the clinic personnel competencies. Jahara and team, may I just check any specific competencies that they must show, or a general competency form will suffice?
What actually, I'm not quite clear what kind of competency we're looking at. Is it your CPR AD, or is it?
Just now they said prepare SOP and competencies, right? I think in Caroline's slide. So we maybe just want to recheck what is this competency that they're referring to?
I see.
For the
Competency.
staff competency.
Understand.
This one
So
question about staff
competency meaning that we want to make sure that your staff understands and has been trained to understand all your processes in place, all the training and whatever you need. So it depends on the role of the staff. If the staff is actually helping you to dispense medication, then the staff must be competent and understands what is the process required and what they need to look out for. I think when we go to the clinic, sometimes we realize that even for solos, you may have where the assistant goes on leave and then someone else come in to replace. It's not that you can't, but that person may not be very familiar with your processes. So we do get mistakes happening. And therefore, we have required that you must make sure that not only they know the SOPs or they know your processes, they know what they're supposed to do, you must also check to make sure that they have the competency, meaning that they know what they're supposed to do properly.
Correct.
And they have been trained and they are able to explain to you that actually they understand the processes. So that's what we meant by competency for your staff.
Okay. I think to address everyone's concern, as indicated by President, we also maybe come up with a competency checklist. But of course, you must modify to your clinic, right? If your clinic don't do this procedure, but your clinic do some other procedure, like you do Botox and etc., then you may have to modify. But maybe we can provide some common competency like onboarding, like how to register patient, how to handle medicine, how to double check, how to label, and all this. And then it's a simple competency checklist. So actually, if I'm not wrong, it's the chief governance officer or the PO that's supposed to check the competency, or check that their own staff is still competent, then you can adapt and use for your clinic. I think it's good to have a competency checklist so that your staff, especially now that with the Healthy SG, there's a lot of new things coming out every day. So just to check that your staff can perform properly, they can recognize an emergency, they know how to prioritize, they know how to talk to you, they know how to dispense properly. And that also will increase the skill level of your clinic. So I think we'll put that in. Then cycling back to the loose medicine question, which I think shared by Dr. Vivian about paracetamol, loperamide, cimetidine, and diaminate, no more loose tablets. I think that one we will have no choice but to travel. Thankfully, DDGH Raymond is concurrently the head of HSA, so he can look into this. But if I'm not wrong, there is still maybe not Asia Pharma, but maybe there are other drug vendors who still sell a certain quantity. It may not be 100 million tablets, maybe smaller than 1,000. Dr. Wong and Dr. Suraj, you're in your purchase of drugs, do you all purchase quantities less than 100? 1,000, sorry, less than 1,000 tablets.
I'm not sure with
Based on the
Pan-Malayan,
product.
you can check with Pan-Malayan website. They do sell in smaller quantities, and they are
Yeah.
also, I mean, also the other thing that they are doing is like, because of telemedicine, right? They are also one of the pharmacies set up to deliver drugs to patients. So in that sense, they actually can prescribe in small amounts, and deliver it. So I don't think there's any rules to say that they have to be in big boxes of stocks, see, right? So
You can buy small quantity depending on the drug. I think I never had a problem, but depends on the clinic usage also. A one single clinic might have low usage. The requirement is much less. But I think you still can purchase smaller quantities. There might be a minimum quantity, but I do not know whether it's 1,000.
Yeah, I think it's more company specific rather than it's a HSA specific rule. Yeah, it depends on the company, whether they want to actually sell in that kind of quantity because they might find it not viable, right? Just to deliver small loose packets.
Yeah, I did a quick online search. There's still clinics that sell, there's still pharma that sell loose medicines and also sell smaller quantities. So I think you DGJ is correct. You can actually can purchase that. And then there is just to answer Dr. Woon's question, I did an online quick search. NHG Pharmacy does provide a emergency drug clinic that meets the MOH requirement. I'll just post a link. It's called pharmacy@nhg.sg, so you can use that. There are many vendors actually, but I will just share that with everyone. Okay. Wow, we have a lot of questions. Thank you everyone for your enthusiasm for a Saturday afternoon. Okay, so lots of questions.
can you buy drugs from Malaysia?
Malaysia, I
question.
cannot buy a ship over. Bring back Canada. Not safe lah. I would say that. I'm not sure about much, but I mean, I don't doubt that Singaporeans love to go cross the causeway to buy for their own personal consumption. But for a clinic sale perspective, you have to be ensured that the drug comes from a legit source, has proper expiry date, is real. So I think there are some regulations, but I leave
No,
it
I
to
don't think you can buy.
Jahara, etc. to address this question.
I don't think you can buy from overseas. It comes under customs and import of just like anything you buy overseas. You need to clear with the import. Probably need a licensing for import of drugs, and let's go to customs as well. But Jahara, am I correct? I mean, if you want to buy drugs for clinic use.
You also need to know that you need to have HSA registered products. So you got to be very careful the kind of products that you bring in. Anything I think Raymond can add on, but anything that you bring in overseas or if it's a named patient, then also you need to get clearance from HSA. So it's not that you can just bring medication and just go to Malaysia and buy the medication and come to Singapore and use it on the patient. So it is important that you get actually HSA registered products.
Right. Even the
No,
equipment
need just
also.
HSA registered products.
Equipment
You
also.
also need to get HSA registered. I mean, we also license the dealers who bring in such.
Correct.
Because the importers and the distributors are all licensed by HSA, and they need to abide by good distribution practices as well. That means when they store, as well as when they purchase, and then when they distribute, we also need to make sure that the stock, the conditions that they bring in, they store, before they even distribute to you, have to abide by certain parameters itself. So we don't know, if you buy from overseas which are not registered and they don't meet such specifications, then in similarly, the integrity of the medications may be compromised. Yeah. So if you are buying for personal use, you can currently, people do go overseas to buy itself, but there's a limit of 3 months of usage per person. Because we do know that some people may want to buy overseas. Then there's a limit of 3 months itself.
But just to Raymond, actually they can buy overseas, but they cannot use it in their clinics for their
Ah,
patients.
yes,
right?
correct,
Yeah,
correct,
yeah.
correct. That's personal use.
It's
Personal
personal
use.
use. Yeah, I thought to clarify, it's personal use. You can't then bring in the medication into your clinic for use.
If you want to really parallel import a rare medicine, whatever, then you have to go through the
Name
necessary
patient,
HSA
yes.
licensing. Yeah, you cannot just everything just go bring a plastic bag over and bring back a IKEA bag over for medicine on your own. Just if that's just to clarify for everyone. Okay, we have a lot of questions. Ventolin tablets is no longer available. I think it's whole of Singapore is no longer available. I've not seen a Ventolin tablet for a few years already. If you want, you have to special parallel import yourself. But the reason is because less and less people use Ventolin tablets because of the reduced efficacy and all this. But I think Dr. Suraj and Dr. Wong are experts of the asthma COPD realm. Maybe you chime in on why Ventolin tablets are not really available.
I think if you ask most experts, Ventolin, oral Ventolin is not recommended. Is inhaled Ventolin is more important. And even then, inhaled Ventolin, now we are very careful of SAVAs, right? Short-acting bronchodilators. You need to have a steroid component. And so they are moving away from standalone SAVAs. And you very important to include the steroid component in the combination inhaler. Or if you are using a SAVA, you need to add in a steroid inhaler as well. But oral Ventolin is not recommended generally for treatment in any.
Yeah, no, the guidelines support that now, and we're actually moving away from the blue inhaler. So if you've got a patient walking around with the blue inhaler, you as a family doctor, you have to start weeding them off that one. They have to go to with the inhaled corticosteroid component in the inhalers as well.
Yeah, so on the same light, there was some question about amitriptyline. If I'm not wrong, there was a contamination issue, so there was a recall. That's why amitriptyline tablet is currently not readily available. But you have to swing to the other supply. I think because amitriptyline only one major supplier, but that one has a contamination. There was if I'm not wrong, there's a recall. That's why there's no amitriptyline. But you can try another brand of amitriptyline that is still available. Yeah, to address Dr. Liao. So question about amitriptyline, no? Okay, we have a lot of okay. We have one question I think I may have to ask Suraj and Tien to explain because it's about this very interesting question from Dr. Ng Ming In, if I got your name correctly. He inherited a clinic from an older doctor with older staff. He feels that they may not be willing to train. I think this question cannot be type answer. You just have to discuss, because you are very seasoned, you have been around, you are really the top of the top already. So for junior doctors who buy new clinics and they inherit some legacy issue, because this one has to be explained over life, how would you advise this doctor?
Then in that case, you do have a SOP problem. You have got a manpower problem, right? I mean, actually, the thing is this: when it comes down to the inspection, okay, in this context, then the inspectors will be asking the staff, right? How do you handle patient complaints, or how do you ensure that a drug is given to the right patient right time? And if the staff is not able to answer, then she'll just be a bit blank, and then she'll stare at the doctor, and then the doctor will have the answer on her behalf, and then you're not going to do very well for the inspection, you see, right? Because the inspection was then, in that case, are you saying that you as the clinic license, you're holding the clinic license, you're not training your staff? How come they do not know? And therefore, you have nothing to show. See, so with the SOP kind of thing, it's not just a piece of paper, but if you actually run through it with your staff, all the staff know where is it's in a file, then it's actually improving your comms with the staff. It's something that is a suggested workflow, and that there's no reason why staff will be resistant to it, right? Unless they are outright trying to sabotage your clinical practice, you see.
Okay, how about Suraj?
Difficult question. I think it's all about, what this whole inspection, clinic inspection focus is on competency and minimum standards, right? That's why you have these inspection guidelines, and what MOH is doing is ensuring that all clinics are safe, right, in terms of their practice. So you must have a minimum competency of your staff as well. And I think that's why you need to ensure your staff have some form of training, either through official courses or even you train your staff themselves. As to whether older staff are retrainable, it all depends on the individual, right? The staff you inherit. But I think if they cannot maintain a minimum level of competency, you might need to reconsider your manpower. Yeah. So I think it's a very individual question. I mean, it depends on each individual staff. I would not say it's based on age. To be fair to older staff.
Yeah, maybe just need a bit of time to engage because they do bring them wisdom, right? They know the patient very well. They can sayang the
That's the
patient very
advantage.
well. They can tell you who to see first, who not to see first. They do have this invaluable experience that the new
Right.
staff may not have. So actually, old staff are very valuable in my opinion. When I inherit a clinic and when I have old staff, I'm very thankful I got old staff because he can sayang this patient very well, can help smooth the edges, can tell you, oh, he even recognize by memory like their whole family. This is the who son of who or who. And they are very invaluable. Of course, they may be difficult to competency, but I think in general, the government now, a lot of skill futures, everything, they keep on encouraging everyone upskill. And then SMA actually has a CA, a clinic assistant course. You can send that. That one is a gold standard for competency. That one you take out any MOH inspection, I think quite impressive. So you can also consider that. Or if not, you can do your own. I think when we say about competency, we don't expect you to like role play, hire a patient and then come and test your stuff or mystery shop. Just maybe a tabletop exercise, just run through some key points, some learning points. I think that is usually most people are open to this level, but you don't really need to force them to do some high level thing. And then I think you can still engage the staff. But I actually value staff who are senior and have experience. Maybe they don't have the paperwork, but they have the more important, which is the street cred and the high EQ. So you still should work to retain that stuff. I hope that addressed your question. I have this question about no specific medical condition, but repeatedly fail practical BCLS. Okay, Dr. Suraj, you're not to age shame you, but you're a very senior veteran. And you're still doing. So what are your thoughts about?
Okay, so this
You're
one,
very fit, of course. You're very fit.
actually a good question because it is a real problem.
Yes.
And it's not easy to pass BCLS if you but of course, you make sure that you choose a vendor that teaches you well, right? The vendor that administers the BCLS course is important. And so they always have minimum standards for you to adhere to. But I do recognize the fact that sometimes it's not easy to pass the BCLS, especially the small things like the cardiac compression rate, the breathing compression, or the delivery of the timing, and so on and so forth. I think it has to be handled on a case-by-case basis. Now, from what Jahara mentioned just now, they will come up with guidelines as to how this is going to be administered. I mean, how this is going to be put in place. That means making sure that everybody is BCLS AED competent. And I think there will have to be provisions on a case-by-case basis on how to handle individuals who simply cannot pass the BCLS. And I think we will need to go back and see what is that particular aspect in which they cannot pass, right? Yes, maybe go down to that level and then see how we can help those individuals rather than say you cannot hold a clinic license because you can't do BCLS. So my answer is a case-by-case basis. I don't have a blanket answer for everything.
Sure. Actually, I think you touched on a very important point. It's probably the vendor. So I myself have tried many different BCLS vendors. Every year I try a different one just to get a feel of it. I can tell you some are very good. They even play music, and then the device is a lot more easier to press. If you need to, you can contact us privately. We can tell you some highly recommended vendors. Really like, I think almost everyone can pass one. Not to tell you cheap, but they are really better. They are better in training, and they're there to support you through it. So maybe a vendor issue. So do consider looking for alternative vendor. You can also reach out to some of us to see whether we can give you privately some context. I mean, not say we hard sell, but you consider alternative vendor. I think it should be possible. But if you really cannot, then do speak to someone about it. Maybe someone can just go through with you privately and just.
I think you will need to talk to the course provider who actually failed you. To what aspect can be improved. You know, the one thing I realize is the course providers are doing what they do, and they have certain standards because it's very important in life-saving. And when you actually have a real collapse case, every small thing that you do will determine whether the patient survives. So you must be able to do CPR properly, right? And if the course provider is a little bit strict or is teaching you certain points that must be passed, there's a reason for it. Because the downside is that if you don't do it well, the patient won't survive. In terms of the way you do cardiac compressions, the way you administer the breathing, rescue breathing, and so on and so forth. Yep.
Okay, so this is an important skill set, basically. It could really be life-saving. Is it true that dentists don't need to do practical above the age of 55? I don't think so, right? I think BCLS is everybody. There is no such thing as an exemption specific to a specialty. Am I correct?
The dentists are more strict, but whether there's an age exemption, I'm going to check with our counterparts in the dental side.
Yes,
I know that they are very strict.
I know there are a lot of questions. We'll try our best to type through and we'll compile a FAQ. But if you have more questions, you can also email us. I think we are coming towards the end of the webinar. At this juncture, I would like to invite DDGH to give some closing remarks. And also thank the MOH team for staying with us on a busy Saturday, and especially DDGH, who's busy fighting the vaping war and taking time out to join us
Thank
from
you.
the vaping war.
No
Thank you so
problem.
much.
No problem. Thank you. Thank you. So thank you, Tien, Nelson, Suraj, for the invitation to partner with CFPS on this. So I think I hope that during the past 1 hour and 45 minutes, all of you would have given given the necessary tips, to have ample preparations. What are the common mistakes? What are the common myths that you may have about inspections? I know always like what Nelson, you mentioned, when you start, everybody is very nervous, it's like taking exams and that. But I think we want to demystify that, and hopefully with this past 1.5 hours, it would have given you enough preparations to know that we have provided the checklist, the SOPs. I think we want to help you as much as we can, because ultimately I think we are all here to ensure that we help you to provide the necessary safe and effective healthcare for the patients. We are not here to start closing down clinics, nor to open up clinics because not to have clinics open up, because ultimately we are all trying to see how to enhance the capacity, especially now that we are opening up a lot more new programs, like for example Healthier SG. So I think there will probably be a lot of questions still. Why so much SOPs? Why so much checklists? Can it be simpler? I think we also look at it from a perspective that, like factories, where they are manufacturing and the supply chains, there's also proper SOPs, guidelines, the good manufacturing and distribution practices that needs to be abided with. And I think SOPs help to conceptualize what are some of the things that you need to put in place for the governance, as well as the processes and the workflows, so that everything that you do there in the clinic, especially if it is to provide patient care, is going to be done in a consistent and safe manner. So that is where we feel is very important. And I think during the telemedicine saga that you probably would have known over the past 1 year, where there has been a lot of debates about Mana Doctor clinics and a few other telemedicine clinics that have been spotlighted, it points out that actually governance and processes of how a clinic is being run, how you actually recruit, train your doctors, and not just your doctors, your locums, and also your clinic assistants will come in very, very useful and important. And going forward, there will be a lot more other areas, like for example, we are also going to roll out things like the Health Information Bill, of which this will be also very important as well. Then I think, there will be a lot of things about, whether about the clinic inspections. And I think during the Q&A, we have informed that the clinic inspections and the renewals are actually dealing already. So most of the time, we will be providing, we will allow the renewal of clinic licenses once every 2 years, regardless of whether it is being inspected or not. So we do not tie it in anymore. Because what we want is we actually take it as an automatic process. If you're good, there are no other things, we actually don't need to go and inspect you after once every 2 years. So we do have our own internal risk-based kind of licensing inspection framework, of which we will then check whether there's a need to go down. And unless there's any compliance issues, complaints, that has arisen, then we don't really need to go down and tie it in itself. So don't worry that by the time you reach inspection time, it has not you have not been inspected, and therefore you may not get a license. So that is being delinked. Then I think there's a lot of questions about why need to submit so early and all these things. Again, I think it is to allow us to have preparatory time. I just want to emphasize that currently what you see, the team here, led by Jahara, is only a team of about 10-ish people that we have. And like what we say, we cover across from hospitals, clinics, medical dental clinics, down to ambulatory surgical centers, etc. So it's not is not a big team, and that's how we also try to make sure that our processes are also and our team is being kept lean and streamlined, such that it does not translate to additional cost for licensing. I mean, I can have a very big team, I can process everything fast, but ultimately all this will translate down to added licensing costs as well. So we are also trying to make sure that we keep ourselves as streamlined as much as possible and trim as much as possible. So going forward, I think, I also see that there's a lot of SCDF and NEA kind of questions. Maybe what we can do is we can also see whether we can bring other partners to answer some of these questions. Because I gather, they are also part and parcel of the licensing process, inspection process, and we may also need to cover these other aspects. Yeah. So again, let me thank CFPS for partnering with us. I think let me thank my speaker, my colleague Caroline, and the team, the licensing and inspection team, for answering all the questions back end, and also for all the participants for joining in this 2-hour session on a precious Saturday afternoon. And I look forward to working with CFPS going forward on a lot more new other topics, like for example HIV, cybersecurity, thematic areas like telemedicine, etc. So I'm sure we will have lots to line up in 2026 onwards, to see how we can support all the GPs in this, family physicians in this process. Thank you.
Thank you, DDGH, and thank you, everyone. I know there are still a lot of questions coming in. I don't want to stop you. In fact, I think it's good that you're asking very good questions. I just trouble the back end room, and as our panelists just look through, because I saw some interesting one like death certification, embu bag size. Embu bag size, do they need both adult and children embu bag? If they see both adult and children, because the volume is different. I think all this, I don't mind. Can I just trouble the panelists to quickly just type in some key answers? Okay, you may have even more questions. Don't stop it. It doesn't end today. Chester, please just type in the chat function both the HASA email and our college email, so that some of these we may reply you by email if we don't have time to verbalize, because we do want to end on time. Next slide. So just to reiterate some key issues. The SOP and the competency forms checklist, college will prepare a general set. We strongly encourage you to have a look at it, but please do customize to your clinic, right? So if you do certain things, you may have to adjust here and there. Number one. Number two, we'll compile all the FAQ, and then we will try our best to type in. Our teams are typing at light breaking speed to answer all your questions. So we will try to type in as much as possible, and those that we cannot type in, you can email the 2 email addresses below that is just shared, that we can get back to you, right? So the next thing is that again, Healthier SG webinars are coming up in October 14, 21st, and 28th. It's free, so if you have not signed up, please sign up for it. Please log in, because these are the next 3 key topics, which is very pertinent to family practice. Next slide. On behalf of Director PCC and HQPCN and MOHD, I'd like to remind everyone who is a healthy SGGP, currently the submission rate is at below 50%. We strongly encourage all GP partners to please submit your health plan and your patient indicators, so that means you're getting half your annual servicing fee. So if you submit before last day of December, you get the full amount. So we strongly encourage everyone to please submit, since you have worked very hard to take care of your healthy SG patients. We still have a lot of unanswered questions. We will, Chester, you will kindly help us to compile it somewhere, right? Yes, Chester also highlighted our email address for queries pertaining to this particular webinar. So please take note of that. It's SFP Singapore Family Physician SFP at cfps.org.sg, and HAXA email is also in the link given. So you can also email HAXA or go to haxa.gov.sg for information. We will release a clean set of both the clinic inspection as well as the CPR slides for everyone to read. Those who are free, please join the MCQ online and get additional CME points so you can meet the requirement. And I thank everyone. Everyone's very enthusiastic. We got a lot of questions, and I saw familiar and new names, so I'm really thankful that everyone was so actively participating. Some webinars is really radio silence. This one is like hyperactive from everyone, and we see all your concerns. We have addressed it. Anything else we cannot answer, please email us. We will email it back, and then we will also compile the FAQ to release to everyone so that you can also share with your friends. And if you have more questions, feel free to reach out. The MOH team and the CFPS is more than ready, happy to support you. If there are no further questions, those who have to log off can log off. Those who want to stay back and answer more questions can answer more type. But I think those who are busy, please go off. You got the 2 CME points already. Everyone got the 2 CME points, right? So you can log off